COVID-19. Describe the epidemiology, mode of transmission, etiopathogenesis, diagnosis, and comorbidities in COVID-19 patients. Case study. A 37-year-old man who was suffering from cold, dry cough and fever from past 3 days went to the doctor for a checkup. During the examination, he also complained of itching in throat and runny nose. The doctor immediately asked for nasal swab testing and requested him to go for self-isolation. A rapid diagnosis was done by reverse transcriptase PCR. The test report showed that the patient was COVID-19 positive. Coronavirus. SARS-CoV-2 belongs to a family of single-stranded RNA viruses called Coronaviridae. The period of incubation of coronavirus varies but is generally up to 2 weeks. Previous coronavirus outbreaks include severe acute respiratory syndrome (SARS) identified in southern China in 2003 and Middle East respiratory syndrome (MERS) first reported in Saudi Arabia in September 2012. Mammals such as camels and bats have been implicated in coronavirus outbreaks, but it is not yet clear the exact animal origin in any of SARS-CoV-2. The structure of SARS-CoV-2 is found to be similar to SARS-CoV with variant size ranging from 50 to 200 nanometer in diameter. The virus has a series of protein spikes on its surface. There are 4 structural proteins which are similar to other coronaviruses, the S, E, N, and M proteins. The S stands for spikes, the E stands for envelope, the N stands for nucleocapsid, and the M stands for membrane. The S protein is responsible for allowing the virus to attach to the host membrane. It contains the receptor binding domain which recognizes the angiotensin converting enzyme receptor 2, ACE2, which is expressed in the lungs, heart, kidneys, and intestines. The other protein on the surface of the virus called hemagglutinin esterase is also responsible for the attachment to the host cell. Epidemiology. Ever since cases were first identified in China in December 2019, the COVID-19 pandemic has exploded. Cases in more than 180 countries have been registered. Individuals of all ages are at risk for infection and severe disease. However, the probability of serious COVID-19 disease is higher in people aged over 60 years. Factors that contribute to the increased burden of COVID-19 include overrepresentation in work environments that confer higher risks of exposure to COVID-19, economic inequality, neighborhood disadvantage, and lack of access to health care. Clinical manifestations in pregnant women are predominantly mild, with few reports of severe disease and fatal outcomes. Pregnant women are often tested for SARS-CoV-2 infection on admission to hospital delivery. Healthcare workers are at high risk of infection because of more frequent exposure to COVID-19 cases and may contribute to the spread of COVID-19 in healthcare institutions. Mode of transmission. COVID-19 virus is primarily transmitted between people through respiratory droplets and contact routes. Droplet transmission occurs when a person is in close contact with someone who has respiratory symptoms, example, coughing or sneezing. The viruses can also survive on surfaces for a few hours, and hence it is possible to get the virus infection by touching contaminated surfaces like doorknobs, utensils, or even infected clothes. The virus can travel even through fecal-oral route also. The rate of transmission of the virus depends on two factors. One is the R0, which is the reproductive ratio, and the other is the serial interval ratio. R0 is defined as the expected number of cases directly generated by one case in a population where all individuals are susceptible to infection. According to the current statistics, the R0 falls in between 2 to 4. The serial interval refers to the time between successive cases in a chain of transmission. The mean of serial interval is found to be 5 days. Etiopathogenesis. Inside the virus, genetic materials contain the information to make more copies of itself. The protein shell provides a hard protective enclosure for the genetic material inside the virus. The outer envelope protects the genetic material in their life cycle when traveling between host cells. When an infected person coughs, speaks, talks, or sings, the infected secretions such as saliva and respiratory secretions carrying the virus may land inside the mouth or nose of another person. And finally into lungs. Then the virus may encounter the cells inside nose, throat, or the type 2 pneumocytes of the lungs. The spike protein and hemagglutinin esterase protein are necessary for the fusion and attachment of the virus cell. The ACE2 receptor is activated by transmembrane serine protease enzyme TMPRSS2. The virus enters the cells in two ways, either by fusing with the cell surface and transfers the genetic material inside the host cell, or through the process called endocytosis. Once inside, the virus releases its genes inside the host cell. Unlike other flu viruses, the coronavirus does not need to enter the nucleus of the host cell. It directly accesses the ribosomes. Ribosomes are the organelles that help in protein synthesis. When the RNA moves through the ribosomes, it gets translated and makes proteins called polyproteins. These polyproteins act as the precursor to make all the viral proteins. The enzyme called RNA-dependent RNA polymerase takes the single-stranded viral RNA and make more copies of viral RNA. Then the viral RNAs and all the viral proteins gets transported to the Golgi bodies for assembling. Finally, the new viruses move to the surface of the cells through the process called exocytosis. Eventually, this whole process causes the death of type 2 pneumocytes. When the type 2 pneumocytes inside the alveoli are damaged, they start to release interferons, which cause an increase in the release of the antiviral peptides and cytokines, which alert the alveolar macrophages and leads to the secretion of inflammatory mediators like interleukin-1, interleukin-6, interleukin-8, TNF-alpha and gamma interferons. These inflammatory mediators move to the pulmonary capillary area and causes the endothelial cells to move closer together, which makes spaces to form in the pulmonary capillaries. This causes the leakage of the fluid between the pulmonary capillaries and the alveolar membrane and causes interstitial edema. Some of the fluid moves inside the alveoli and causes the alveolar edema. The buildup of the cytokines and other inflammatory mediators inside the alveoli can cause damage of type 1 cells of alveoli, which impairs the respiratory gas exchange. When the partial pressure of oxygen decreases, it can cause hypoxemia. In the critical illness cases, the carbon dioxide in the blood starts building up and causes hypercarbia. And finally, this could lead to respiratory acidosis. The decreased amount of healthy type 2 alveoli cells can cause decrease in the surfactant production, which in turn increases surface tension. The increased surface tension can lead to the collapse of the alveoli. This causes the main symptom called dyspnea or shortness of breath. The cytokines can also increase the activity of the procoagulants. Procoagulants are molecules which promote clot formation. The increased clot formation can cause pulmonary emboli. Sometimes an overactive coagulative system could cause disseminated intravascular coagulation, DIC. The inflammatory mediators further release the molecules like leukotrienes, prostaglandins, etc. This molecule then activates the receptors that connect to the vagus nerve in the central nervous system and results in the generation of cough. The cytokine storm can also act on the hypothalamus and disturbs the thermostat, which results in the high body temperature. The thrombotic effects provoked by endothelial dysfunction can also predispose towards strokes and hepatic dysfunction. Microvascular as well, macrovascular injury can potentiate acute renal failure. Thus, loss of the endothelial protective and unleashing of the mechanisms depicted can lead to multi-organ system failure in COVID-19. The other symptoms include diarrhea, body ache, sore throat, loss of smell, loss of appetite, confusion and headache. Researchers have seen the following complications in people who have developed COVID-19: irregular heart rate, severe muscle pain, fatigue, heart damage or heart attack. Diagnosis. The sample collections from upper respiratory tract includes the nasopharyngeal swab and oropharyngeal swab. The sample collections from lower respiratory tract includes bronchoalveolar lavage, tracheal aspirate and sputum. In the nasopharyngeal swab collection, the swab will be gently inserted into the nostril straight back in a direction that makes a line from the nose to the level of the earlobe. The swab should travel along the floor of the nose. When the resistance from the nasopharynx is felt, the swab will be rotated few times to collect the cells. The swab will be transported in a container with the transport medium. The standard method of coronavirus testing is the polymerase chain reaction. PCR is used to make millions to billions of copies of a specific DNA fragment rapidly. To detect the RNA molecules of coronaviruses, the RNA molecules must be converted to their complementary DNA sequences. DNA primers recognize unique RNA sequences within the viral genome. After the first primer binds to the viral RNA, the enzyme called reverse transcriptase synthesizes a single-stranded DNA copy of the viral RNA known as complementary DNA or cDNA. The RNA is removed and the second primer binds to the other side of the single-stranded cDNA. Then a second enzyme called Taq DNA polymerase extends a second strand to produce a double-stranded DNA copy of the target region of the viral RNA. This undergoes successive rounds to produce a greater number of copies of viral RNA. Then the fluorescent probe is used to detect the target DNA. If the DNA profile matches the profile of the virus, the test will be positive. The other types of testing include identifying the antibodies to the virus which are present in the blood. Antibody test rounds to produce a greater number of copies of viral RNA. Then the fluorescent probe is used to detect the target DNA. If the DNA profile matches the profile of the virus, the test will be positive. The other types of testing include identifying the antibodies to the virus which are present in the blood. Antibody testing looks for IgM antibodies which appears within days of an infection and IgG antibodies which remain in the blood and provide long-term protection. For the diagnosis of COVID-19, although RT-PCR is specific, its false negative rate cannot be ignored because of the severe consequences of missed diagnosis. So many clinicians propose CT scans should be one necessary auxiliary diagnostic method because it is more sensitive. For individuals with a high clinical suspicion of SARS-CoV-2 infection with negative RT-PCR screening, a combination of repeated RT-PCR tests and chest CT scan may be helpful. Like the RT-PCR test and unlike antibody tests, antigen testing looks for the presence of SARS-CoV-2 virus in the body. In an antigen test, a swab is taken from a person's nasal cavity and it is tested to detect fragments of proteins which are found on or within the SARS-CoV-2 virus. The other parameters examined are decreased albumin, high C-reactive protein, high lactate dehydrogenase LDH, lymphopenia, high erythrocyte. COVID-19 patients with history of hypertension, obesity, chronic lung disease, diabetes, and cardiovascular disease have the worst prognosis and most often end up with deteriorating outcomes such as acute respiratory distress syndrome, ARDS, and pneumonia. Since there is a period where the patient is asymptomatic and the incubation period is between 2 and 14 days, it is difficult to establish an early diagnosis. However, within this period, if respiratory symptoms develop, it is important to seek immediate care. Therefore, patients with comorbidities should take all necessary precautions to avoid getting infected with SARS-CoV-2 as they usually have the worst prognosis.